Next up, I'd like to introduce Dr. Woodrow Corey. Dr. Corey is a board-certified cardiologist with St. Vincent's Medical Group, a part of Ascension. He provides acute and chronic care and preventive care with an emphasis on diabetes and lipids to all his patients. Dr. Corey has a special interest in congestive heart failure, lipids, and diabetes. He develops close relationships with patients and their families and strives to maintain a continuity of care. He treats every patient as a unique individual and develops personal treatment plan for each patient. Dr. Corey holds an undergraduate degree from DePaul University, attended IU, Indiana University Medical School, and completed his fellowship at the University of Cincinnati. Outside the office, Dr. Corey enjoys running, American history, and music. Dr. Corey, the floor is yours. Thank you.
Thank you. All right. Are the slides visible? Okay, good. Well, I want to first off thank everyone for giving me an opportunity to talk to you today about a topic that is very common, that all of clinicians see in their practice almost on a daily basis, but it's a topic that I'm very passionate about, and that's the treatment of the cardiac patient with diabetes. And as most of you know by now, there's been a boatload of data and research that's been done in this area over the last 3 to 5 years. And the clinical trials come out almost on a monthly basis. And what we've found are some very unexpected, surprising results from these trials. Again, we're talking of multiple trials. And so I've got 20 minutes to go over a lot of data. So I'm going to move very quickly, but I'm going to focus in on some of the more important of those trials that I think will have the most impact on how we move forward through the next 5 to 10 years and how we treat our patients. So just to kind of set the stage, we know diabetes affects multiple different organ systems in the body. You can get blindness, you get amputations, you get neuropathy, but really when you look at what actually unfortunately kills patients, up to 80% of the time, it's a cardiovascular related event. We know that if you have type 2 diabetes, it doubles your risk of having cardiovascular disease. Just having diabetes alone, just carrying that diagnosis cuts off about 7 years of life from the average patient with diabetes. If a type 2 diabetic has an MI, you can subtract about 11 years off that life. And if unfortunately they happen to have a stroke and an MI, they lose almost 16 years of life. Now, the interesting part about diabetes is up until 1990, there was really no hard data to show that controlling glucose levels actually impacted outcomes. It wasn't until at the end of 1990 when a study called the DCCT trial, or the Diabetes Control Complication Trial in type 1 diabetics, showed that if you use tight glycemic control, which was measured by the A1C, you can actually reduce nephropathy, neuropathy, and retinopathy. Those are what we call microvascular complications. What it didn't show was just as important as what it did show. It did not show a reduction in macrovascular complications, meaning it had no impact whatsoever on cardiovascular and stroke-related deaths. And that bothered clinicians and researchers. And over the next 35 years, multiple large clinical trials and billions of dollars were spent to try to connect the A1C to cardiovascular and stroke outcomes. And these are 4 big trials that I listed on this slide that tried to connect those dots. And unfortunately, at the end of the day, when you do a meta-analysis of all those trials, we find absolutely no clear-cut connection between A1C or glycemic control to cardiovascular death and mortality. You can see the hazard ratios for all of these were greater than 1, meaning there was no real benefit. It got even more complicated. In the mid-2000s, around 2006 or 7, you could recall there were 2 diabetes drugs on the market in the United States, rosiglitazone and pioglitazone, or Actos and Avandia, that were causing some concern because it seemed like it was worsening congestive heart failure and maybe even causing premature death in some of the cardiovascular patients. And it got to a point in 2008 that the FDA got involved and they put out a guidance. And it was a pretty bold guidance. It said moving forward from 2008 on, any new diabetic agent that was going to be used in the United States to treat diabetes in a cardiac patient had to do what we call a cardiovascular safety outcome trial. So they had to not only show that they were effective in lowering glucose, which they have done already, but they had to do an additional trial called a safety trial to show that it did not cause any harm to a cardiac patient. Well, you can imagine the amount of uproar that caused in the pharmaceutical industry. You know, they had to spend a bunch more money and more time to show that their drugs were safe. But the FDA mandated it. And what they mandated was that they had to use a specific endpoint in these safety trials called a 3-point MACE, which is a common endpoint we use in cardiovascular trials. It's a non-fatal stroke, non-fatal MI, and cardiovascular death. And this slide just shows you the number of studies that had to be put together in that period of time. And they started in 2013, and they're continuing to go on even to this day. They come out every few months with a new study and new outcomes. But you can see just the sheer number was overwhelming. This slide just looks at the drugs that were being studied in these safety trials. For the most part, they came from 3 broad categories of the newer diabetic drugs. The first one was called the Dpp-4 inhibitor class. And the second one was called the Glp-1 Agonist class. And then the last class was the SGLT2 inhibitor class. In the middle column here, you see the name of the drug. And I just quick, easy way to remember this. If it ends in gliptin, it's a Dpp-4 inhibitor. If it ends in glutide, it's a GLP-1 agonist. And it ends in gliflozin, it's an SGLT2 inhibitor. I don't want to give you a lecture on pharmacology, but I do want to spend just a brief amount of time to tell you how each one of these drugs work, because I think it's helpful. So if we look at the Dpp-4 inhibitor group, those are drugs, again, like Januvia, Trajenta, and those types of drugs. In the body, there's a natural enzyme called the Dpp-4 enzyme. The natural action of that enzyme is to inhibit GLP-1. GLP-1 is a good thing because what it does is it helps the pancreas secrete insulin and it reduces glucagon secretion, both of which lead to lower glucose levels. It also acts on the intestine to slow gut motility, and it acts on the brain to suppress appetite. So we have a natural inhibitor in our body called Dpp-4. So what we did is develop a drug that inhibits the inhibitor that gives us more GLP-1. So you get more glycemic benefit. The other class is called GLP-1 agonist. It's another way of doing the exact same thing, except you actually administer more of the GLP-1. And you can do this through an injection. And again, it has the same actions, acts on the GI tract to slow it down, gut motility, acts on the brain to suppress appetite, and acts on the pancreas to increase insulin and reduce glucagon, both of which lead to lower glucose levels. The third class of drugs were the SGLT2 inhibitor group. This group works in the nephron. In the proximal tubule of the nephron, we have a natural transporter called the sodium glucose transporter. What happens usually is the blood comes into the glomerulus, it gets filtered, and then you form urine, which gets put into the nephron, into the tubule. When the urine's traversing through the tubule, this transporter will reabsorb glucose and sodium back into the system. That's what our body does normally. What we can do is we can administer a sodium glucose transporter inhibitor, and it blocks that transporter, so then the sodium and glucose doesn't get reabsorbed. It gets put into the urine and gets wasted into the urine. So you lose a fair amount of glucose and a fair amount of sodium. Well, like I said, these companies had to do these safety trials, and the first set of safety trials started to come out around 2014, 2015. And the first category of trials were with the Dpp-4 inhibitor group. And what they showed was exactly what they had hoped for. They showed that these drugs were safe. That was the main objective. It was not to show that they were superior. It was to show that they caused no harm to the cardiac patient. And if you look at the hazard ratio, they fell right on the line of unity at 1.0. So they were neutral. So everyone was excited. The companies were happy. The FDA was happy. So they could market their drug. And that was that. And that was the status quo until 2015. And in 2015, a study came out that will probably go down in history as one of the most important trials of our time. It changed the entire paradigm of how we're going to treat our patients with diabetes and cardiovascular disease. And I want to spend a minute on this trial. It was called the Empa outcome trial. And it was looking at an SGLT2 inhibitor called empagliflozin or Jardiance. And the way the trial was designed was, again, you had to have cardiovascular disease to get into the trial. You had to be on standard of care, everything you normally would use to treat that patient. And then the patients got divided into two groups. One group got empagliflozin and the other group got a placebo. And then they followed them out and they used the 3-point MACE as the primary endpoint, which was non-fatal MI, non-fatal stroke, and cardiovascular death. And at the end of 4 years, this is what we found. We found that just by adding this one drug to the already gold standard therapy that these patients were receiving, you could reduce that 3-point MACE by 14%, meaning you could reduce non-fatal MI, non-fatal stroke, and cardiovascular death by 14%. That was the first time ever in the history that a diabetic medication showed a reduction in these hard endpoints for the heart. So they then went back and they looked at the individual components of the 3-point MACE. Remember, that was non-fatal MI, non-fatal stroke, and cardiovascular death. And they looked specifically at cardiovascular death. And this slide showed that this was the most unreal finding of the trial, that it was hard to believe at the time, but it showed a 38% reduction in cardiovascular death if you took this drug compared to the placebo. Again, on top of everything else you normally would give these patients. What was even more striking is if you go back and look at how early the curves started to separate, they separated by day 59 with a statistical difference by day 59. Then they went back and they looked at other individual components. They looked at all-cause mortality. They showed a 32% reduction of death by any cause. And then another big surprise was a reduction in admission to the hospital for congestive heart failure by 35%. Again, started very early on. If you look at how quickly these curves started to separate, it was from the very first few weeks. Again, these were incredible findings, unexpected. You know, in medicine, sometimes, you know, we get surprises when we do research. And it was pure serendipity that these drugs that were forced to do these trials had such positive findings. If the FDA had not mandated they do these trials, we may have never known about these findings. The one thing that I want to stress was when they went back and they did a sensitivity analysis on the patients that got the drug and the patients that did not get the drug, what they found was they looked at the hemoglobin A1C, which is a metric to measure your glycemic control. And what they found was it didn't have any relevance on the cardiovascular benefits. Now that sounds familiar if you go back to the beginning of my slide where I said they have never been able to show glycemic control impacts cardiovascular death or heart endpoints. That same thing happened in this trial, in this Empa outcome trial. So the question came up is if it's not related to glycemic control, because patients who had very little A1C reduction still got the benefit, then what's the mechanism? And that was the hard question to answer. And until this day, we still do not have a definitive answer. But we know these drugs do multiple positive things. And this slide kind of lists a few of them. Number one, obviously they lower glucose some, and they have an anti-glycemic effect. But again, remember they work through the kidney, so you lose glucose and sodium, so they act as an osmotic diuretic. That's another mechanism. You lose calories because you're pulling glucose into the urine, and you lose about 300 to 400 calories per day. So the average patient loses around 8 to 10 pounds of weight. You get a blood pressure benefit from this drug. You get that blood pressure benefit without a reflex increase in heart rate, which is a very good thing from a cardiovascular standpoint. So we think it has an impact on the sympathetic nervous system by inhibiting the sympathetic nervous system. We think it has a negative effect on oxidative stress, reducing oxidative stress. And one other thing it does that may be the most important one is it may shift the way our body utilizes its energy substrates. Normally, your body, when you eat, you break down food into glucose and other things, and the myocytes will take up glucose if it's available. And glucose then gets converted into energy. If you remember your biochemistry, you get a glucose, goes into the Krebs cycle with an oxygen atom, and then it churns out 2 ATP. That's a measure of energy. That's how we measure energy. When you use one of these drugs, you push the patient into a mild ketotic state. So they make ketone bodies. And one of the ketone bodies they make is beta hydroxybutyrate. The heart would prefer a ketone body if given a choice between glucose and a ketone body. And the reason is when a ketone body goes into the Krebs cycle with 1 oxygen atom, you actually get 3 ATP for the same amount of oxygen. So you're getting a 35% increase in energy production for the same amount of oxygen utilized. So that may be one of the reasons that we're seeing such a huge benefit in these patients with congestive heart failure or weak hearts or patients who are low in oxygen. So just to recap real quick, this study showed 14% superiority with regard to the primary 3-point MACE endpoint, a 38% reduction in cardiovascular death, a 32% reduction in all-cause mortality, a 35% reduction in admission to the hospital for heart failure, and it was a very safe and well-tolerated drug. The only safety issue or adverse event that occurred from a statistical standpoint was the patients who took the drug had a higher rate of genital yeast infections. So that was the drug that set the stage for the rest of the trials to come out. So then rapidly after that, we started to see other trials complete their studies and to add more to the story. The next trial that finished was called the LEADER trial. This was with Victoza or liraglutide, and it showed a similar finding, a 13% reduction in the 3-point MACE. It showed a 22% reduction in cardiovascular death, but it didn't really show much of a benefit with regard to heart failure. The next trial that came out was with another Glp-1 agonist called semaglutide or Ozempic. And again, it showed a 26% reduction in the primary composite 3-point MACE endpoint. But it did not show any benefit with regard to cardiovascular death or hospitalization for heart failure. The next trial was another SGLT2 inhibitor called the CANVAS trial with canagliflozin or Invokana. It's interesting, it showed exactly the same amount on the 3-point MACE, a 14% reduction in 3-point MACE, and similar reductions in heart failure, but it didn't show a statistically beneficial effect on death. And that had to do with the way the hierarchy of the statistics, the way the study was structured more than anything, in my opinion. The next study was a little different. It was again, another SGLT2 inhibitor called the Declared Timmy 58 trial. And what they did was, prior to this, all the other studies only included patients who had an existing history of cardiovascular disease, along with diabetes. So in this trial, they wanted to see if you could include patients who only had risk factors for cardiovascular disease, not actual cardiovascular disease. So in this trial, about 40 to 50% of the patients had only risk factors and did not have an actual event to the time they were enrolled in the study. So the FDA allowed them to have another extra endpoint. They had their traditional 3-point MACE, but they let them have another endpoint called, it was a combination of heart failure, admission, or CV death. And what they found was the MACE, the 3-point MACE, was a slightly better than the control arm, but not statistically better. But the other endpoint was superior. It showed a significant reduction of about 17% in the reduction of heart failure, admission, and cardiovascular death. And you may say, well, why didn't this 3-point MACE show a superiority? Well, it showed benefit. It was 7%, but it didn't meet statistical significance. And the reason I think it is because it included healthier patients, patients who had not had an event yet. So it was harder to show that benefit in a patient that was not as sick as the other groups of patients studied prior to this time. The next study was another trial with an GLP-1 agonist called duoglutide or Trulicity. Again, this was different than the prior GLP-1 agonist studies because it also included primary prevention patients, just like the previous study I just showed you. But this was with a GLP-1. And it did show superiority. It showed a 12% reduction in 3-point MACE when this drug was given to patients who had just risk factors who didn't have an event yet. So it showed both primary and secondary prevention. About 60% of the patients in this study were primary prevention. The next trial was with an oral. So everything, all those GLP-1 agonists to so far have been injectables. This was a first of a kind, an oral GLP-1. And it was studied in the Pioneer 6 trial, and it showed exactly what we had hoped for. It showed cardiovascular safety. It was not large enough to show superiority, but it did show safety, and it showed that it did not cause harm, so it met its primary endpoint. Now, we've talked a lot about heart disease and the risk of heart disease with diabetes, but I'd have to tell you there's another big organ in the body that gets devastated by diabetes, and that's the kidneys. When you look at the #1 leading cause for going on dialysis today, it's diabetes. It's type 2 diabetes. And you can see from 1980 to 2014, how quickly this has escalated. It's because the incidence of diabetes has gone up significantly. You know, right now we have an epidemic of diabetes. We have about 32 million patients with diabetes. That number is going to be 50 million by 2030, and by 2050, it's estimated, unless we change our ways, we're going to have 100 million type 2 diabetics in the United States alone. Well, you can imagine what that's going to do to the rate of kidney failure and need for dialysis. Well, the problem with kidney disease is there's very few drugs that can help it. We only have 2 drugs that have ever been shown up to recently that have ever been shown to be beneficial. And those were called ARB and blockers, losartan and irbesartan. They showed a 16% reduction with losartan and a 20% reduction with irbesartan, which is a good thing, but it's not a whole lot. And these both came out in the early 2000s. Since the year 2000, there have been multiple trials with different drugs and different mechanisms of action. And that shows this on this slide, trying to show that you could slow down diabetic or any kind of nephropathy once it starts. And unfortunately, every one of these trials failed. Not one.
Sorry, Dr. Corey, 5 minutes.
Okay.
Thank you.
We then showed, so the trials, those cardiovascular safety trials, showed a hint that they were benefiting the kidney. And those trials, again, gave birth to additional trials, which I'm going to go over real quick now because I only have 5 minutes. They showed that you could benefit the kidney. This trial was called the Credence trial with canagliflozin, and it was primarily looking at kidney endpoints. And what they found they had a 2-year interim analysis where they unblinded the data for safety reasons to make sure it wasn't causing harm. What they found was such overwhelming benefit that they had to stop the study early because it reduced that kidney endpoint by 30%. And it slowed down the reduction of your GFR declined by almost 60% over a 2-year period. That was unheard of. Nothing in history has ever done that. So that was, again, in patients with established kidney disease and diabetes. So then we got brave and we did another study looking at, well, if it's not related to A1C, what if we gave one of these drugs to a non-diabetic patient? Would it have the same benefit for kidney disease? They did this called the Dapa-CKD trial with dapagliflozin. Again, they looked at non-diabetics and diabetics to see if you can slow down the loss of GFR. What they found at the 2-year point, they unblinded the study again. Exact same thing, overwhelming efficacy. They pulled the plug on the study because it would be unethical to continue. The FDA currently has this study in their hands. This drug will soon get an indication to use for patients with GFRs that are declining, and it doesn't matter whether they're diabetic or non-diabetic. We know that patients with diabetes have a much higher risk of having congestive heart failure. So again, we saw that in those prior trials. So another trial was put together to look at whether or not you could use one of these drugs in a non-diabetic patient with heart failure to see if it helped. What we found was this was called the dapagliflozin heart failure trial. They included 50% of patients with diabetes, 50% without diabetes. If you had an EF below 40%, you got in the trial. It showed an overwhelming 26% reduction in the primary endpoint, which was CV death and admission to the hospital for heart failure. Again, it worked just as well in the non-diabetic population as it did in the diabetic population. So this is that slide that shows you the benefit was consistent with diabetics and non-diabetics. So another study that just came out recently was called the Emperor Reduced Trial. It was with empagliflozin, same type of trial, looking at people with EFs below 40%. Again, diabetics and non-diabetics. At the end of the study, it showed the same benefit. They showed a 25% reduction in the clinical endpoint of CV death and hospitalization for heart failure. Again, the FDA now has approved dapagliflozin for use in that indication for non-diabetic patients. You could use it if they have an EF below 40%. Jardiance or empagliflozin will soon have that indication. They're looking at that right now because that study was just done not too long ago. Lastly, they looked at kidney function in the Emperor Reduced trial, and they found a similar benefit where it slowed down the decline in the GFR by about 55%. So again, we now have these studies that are just incredibly beneficial. Again, like I said, these are surprises. We would have never known about these if the FDA didn't make us do those studies. But we now have what we would consider diabetes drugs that are now showing huge benefits in non-diabetic patients with regard to reduction of death and heart failure admissions if your EF's below 40%, and slowing down the progression of nephropathy in both diabetics and non-diabetics. This is the last slide I want to show you. It's called the Soloist Trial. Again, this was just recently presented. It's looking, before all these trials were looking at patients who were not in the hospital. These were outpatients that had stable heart failure. For the first time, they did a study where they looked at patients who were in the hospital, had acute heart failure, to see if you could give one of these drugs early in the phase of the heart failure. And they did this called the Soloist Trial. And what they found, again, a 33% reduction in that endpoint of CV death and heart failure admission. This is just a quick slide that looks at all the different studies. Unfortunately, we don't have time to go through it, but the SGLT2s and the GLP-1s inhibitors are the drugs now cardiologists focus in on. The Dpp-4 inhibitors, in my opinion, have almost no role for cardiologists. You can use them for glycemic control, but they do not impact cardiovascular or renal outcomes. The ADA, as Mona mentioned, has now come out with new standards of care, and they're basically saying it doesn't matter what your A1C is. If you've got the disease, you should use either an SGLT2 inhibitor or a GLP-1 agonist. If it's predominantly heart failure, it should be an SGLT2 inhibitor. If it's renal disease, an SGLT2 inhibitor. If it's atherosclerosis, you can use either one. This is that slide that Mona showed you earlier. So this is just a summary. We've already gone over that. Lastly, what we did at my facility is we started a cardiometabolic center because this has happened so rapidly. The clinicians and even the FDA has had a hard time keeping up and getting the indications out there. And some of the cardiologists are a little gun shy about using these drugs because they still think of them as diabetes drugs. So I started a clinic called the Cardiometabolic Center, where we're bringing all our diabetics with cardiovascular disease or risk factors through this clinic. I have a nurse practitioner, a dietitian, and we manage the patient with all the other physicians on the team, including endocrinology, nephrology, ophthalmology, podiatry. It's a multidisciplinary approach that we're going to have to use with these patients now that we have these incredibly effective drugs that we never dreamed of having 5 years ago. So that's what I had to say. I wish I had more time because we're at the tip of the iceberg with this. I think we're going to see that these drugs will continue to be used more and more and more. And 10 years from now, we'll look back and go, boy, that was sure a great time to be in the middle of cardiometabolic disease. So that's it for me. Any questions, I'll be happy to answer.